Hello, everyone. Welcome to ASFA's second webinar of the dedicated webinar series honoring APHERESIS Awareness Day 2024. APHERESIS Awareness Day will be celebrated on September 17th. The purpose of APHERESIS Awareness Day is to raise awareness of apheresis medicine and pay tribute to the many donors, patients, and apheresis practitioners that have dedicated their lives to saving others by using evidence-based practice to advance apheresis medicine. Today's webinar is entitled Optimizing Cell Collection, presented by Deisen, Lauro. My name is Ernest, and I will be your webinar moderator today. Before we get started, I'd like to briefly go over the format for this presentation. There will be a 15-minute Q&A segment and a 15-minute Q&A. There will be a 45-minute presentation segment and a 15-minute Q&A session. Please note that today's webinar is being recorded. You may post written questions at any time using the chat box beside the slides. All questions will be addressed during the subsequent Q&A session. I would now like to introduce our presenter. Deisen Lauro is a clinical educator at the City of Hope Comprehensive Cancer and Research Center. She specializes in therapeutic apheresis and has significantly advanced training and clinical performance since 2021. With a nursing degree and certifications in teaching and QIA, she is celebrated for her expertise and commitment to patient care. Deisen, I will now pass it over to you.
Hello, everyone. I'm Deisen. When ASFA asked me to give this presentation, I took a moment to reflect on what I could bring to the table. And it became clear to me that the heart of what we do at City of Hope is actually cell collection. So through this vital process, I've had the privilege of accompanying many patients on their journey. Because the heart of what we do at City of Hope is cell collection, I have witnessed both the triumphs and challenges for transplants and journeying with our patients throughout this treatment process. And what stands out to me is how profoundly our support and knowledge impact our patients and their families in their treatment journey. And that is why I'm here to talk to you today about optimizing cell collection. So I'm going to go ahead with the webinar. And I have no disclosures. So when we say optimizing cell collection, we're not just talking about the cell yield, but it also refers to improving the overall collection process for various applications such as research or therapeutic purposes. And the goal is to maximize efficiency, quality, and yield while minimizing errors, cost, and time. So today we have 4 learning objectives. The first one is to define the principles of optimizing cell collection. So defining it by understanding key factors that influence the efficiency and effectiveness of the process, including equipment and system requirements. Next is to analyze external factors affecting collection efficiency, such as the patient physiology, procedural techniques, to improve the overall performance and outcomes. And third is to identify and articulate the endpoint goals of cell collection and how these goals guide adjustments and operational strategies to ensure successful outcomes. And the last objective is evaluate and adjust variables to optimize the cell collection run, including flow rates, anticoagulant levels, and other critical factors and parameters to enhance the collection efficiency. So what are the factors that affect collection efficiency? So cell collection, such as for stem cell or bone marrow transplant or research, involves several critical factors that affect the efficiency of the process. So here I'm going to talk to you about the factors influencing collection efficiency. So I'd like to start with patient health. So the patient's overall health, including bone marrow readiness for mobilization, plays a crucial role in higher cell yield. So for example, we have had patients who don't mobilize well. At City of Hope, when we do our collection, our first day of collection for HPCA, we draw a pre-CD34 count. And if that pre-CD34 count is less than 15, for example, what we do is try to give them Mozibil or mobilize them. But there are times that despite the the mobilization medications that we give them, they just don't respond. They don't mobilize. So when this happens, our physicians actually put them on a 2-week hold. That way, their bone marrow has enough time to recover and respond better to the mobilization drugs. And we've also had incidents where we have patients who have adverse reactions to mobilization drugs, such as, elevated troponin, chest pain. And when this happens, we actually put our collection on hold until the patient is stable. Because if the patient is not stable or not mobilizing well, not responding to the treatments, then we just won't be able to collect the cells. The efficiency of cell collection will not be there. And the next factor that affects collection efficiency is the donor health and compatibility. So I'm speaking more about our allogeneic donors. So the overall health and suitability of the donor play a crucial role. A healthy donor with compatible cell types such as HLA or ABO ensures a higher cell yield and a better quality of collected cells. And third is the patient and donor preparation and pretreatment. So, adequate preparation, including education, hydration, and pretreatment with medications or growth factors, can optimize the cell yield and efficiency of the cell collection. In our institution, a week before a donor or a patient goes through a cell collection, we actually give them a 30-minute education. So, during this 30-minute education process, we start by giving them a tour of our unit. We show them the bed, the machine. That way, it kind of like helps them to relieve anxiety or nervousness when they come in for their collection. Because as operators, we know that if your patient or donor is tense, their veins just start to constrict, and it's harder to collect those cells efficiently. And during the education process, we also talk to them about the diet. We encourage increasing diet, in high in iron and electrolytes, potassium, magnesium, just to aid them in this mobilization and collection process. And we also talk to them about the GCSF scheduling. So since we do our collection in the morning between 7 to 9 a.m., we remind them and we let them know that they have to take their GCSF, such as Neupogen, in the morning. Like they have to, our physicians actually tell our patients that you have to bring it up. If you get your first dose of Neupogen in the afternoon, let's say 2 p.m., the next day bring it up to 2 to 3 hours. That way, by the time they start their collection on day 5 of GCSF, they're getting the Neupogen in the morning. That way, as their cells are spilling out of the bone marrow at the peak of the GCSF, they are actually collecting on the machine already. And we have actually found out that this helps with the collection efficiency. We also talk to them about the collection process itself, again, to help them with any questions that they may have. And on the day of collection, we re-educate them again about the collection process and possible side effects, and just answer any questions that they may have. And this overall helps them prepare them for the process. And fourth is the collection method. So the technique used for collection, whether it's bone marrow aspiration or peripheral stem cell collection via apheresis, also affects efficiency. Generally, apheresis collection is preferred because it is less invasive and there is actually higher cell yield compared to bone marrow aspiration. So other key factors are, of course, your apheresis equipment. The quality and calibration of apheresis machines can impact efficiency. Machines must be kept well maintained, cleaned properly, using, of course, manufacturer recommended cleaners. And we have to make sure that there's no scratches on the sensors, because the sensors, such as the AIM and the optical sensor for the amicus, is what actually helps to see those cells so the machine can properly separate them. And modern, well maintained equipment typically offers better performance and higher collection rates. And number six, it's also very important, is the mobilization protocols. So for peripheral stem cell collection, effective mobilization protocols such as the use of GCSF or in combination with Mozobil are also crucial. So historically at City of Hope, we only gave Mozobil to our poorly mobilizing autologous patients. However, we have had allogeneic patients who also poorly mobilized. So a few years ago, I actually gathered 7 years worth of data and realized that we have actually helped our allogeneic patients collect faster in a shorter amount of time by giving them Mosabil. So because of this, we were able to publish a research article proving that donors can also benefit from Mosabil, and it shortens the collection days due to higher cell yields. So because of this, we were able to accommodate more patients towards the end of the week because our patients are mobilizing better and collecting faster. So proper mobilization ensures a higher concentration of hematopoietic cells in the blood, facilitating a more efficient collection. Seventh key factor is the collection timing. So timing of the collection is relative to the donor's mobilization regimen. This also affects efficiency. So like what I said earlier, the proper timing of mobilization and collection impacts the collection efficiency. So in our institution, since the Mosabil peaks within 10 to 15 hours after it's administered, our Mosabil is given between 6 to 7 p.m. at night. And then we start collection between 7 to 9 a.m. in the morning. This way, when this drug, the Mosabil peaks, we are, certain that our patients are actually on the machine and collecting. So optimal timing ensures that the maximum number of hematopoietic cells is available for collection. Eighth is the collection volume and duration. The volume of blood processed and the duration of the apheresis procedure also affect efficiency. So there are times that longer procedures or multiple collections might be required in order to achieve the desired cell count or goal. And ninth, of course, is the type of access. So we're thinking about CVC versus peripheral. At City of Hope, the way we determine the right type of access for our patients or donors is that a week before the cell collection for all of our allogeneic IRB and CAR-T patients, we do a vein assessment. So during the vein assessment, there's always two nurses to assess the veins to make sure that we don't miss anything and to make sure that we have two apheresis practitioners who would agree that their vein is really suitable for collection. So there are times that okay, so assess the vein suitability for the procedure itself. So for example, if someone is collecting for CAR T cell therapy, there is no way that we can risk, a vein that might be. What I'm trying to say is we have to make sure you have more than two veins available for collection, because what happens is if one vein fails, especially for CAR T or IRB collections, then it's just a whole process of rescheduling that patient and delaying the procedure. There's just more factors involved to reschedule everything. So when we are collecting CAR T or IRB, we have to be certain that we have more than two veins available for collection. And of course, if they fail, we recommend them for a midline or CVC placement. And despite them having CVC or midline, we still encounter issues with flow rates. So when this happens, we are actually forced to look for another vein. We have nurses who are excellent at finding veins. And typically, whichever has a better flow rate, we may use one line of the CVC for draw or return and use the vein for draw or return. Whichever has a better flow rate, we use that for draw. Okay, so next key factor is the quality control. So monitoring and quality control throughout the collection process also ensures that the cells collected meet the required standards for viability and purity. And then, of course, we have the technical expertise. So the skill and experience of the medical staff or operator involved with the collection process is also very critical. So at City of Hope, we are very strict with our training, our new nurses or operators. We begin by giving them the theory, the background of the procedure and the diagnosis of the patients. And then we do an SOP review. And then we start, before they actually touch the machine, we have like an operational training that's given by the manufacturer. In our institution, we use both Amicus and Optia. So we schedule operational training with their trainers to train our staff because they are the experts on these machines. And then after that, once they're qualified to actually use the machine, we give them the hands-on training with the preceptor and together with a patient for an actual collection. So We do our training via simple to complex procedures, and in order to maintain competency, we rotate our nurses with the type of collections that we do, auto, allo, IRB, or CAR T cell for commercial collection. So rotating just to ensure that everyone is competent in doing these procedures, throughout the year, for example. So properly trained operators can manage the procedure more effectively and troubleshoot any issues that may arise. And then 12th is the post-collection handling. So proper handling and immediate processing of the collected cells are essential to maintain cell viability and quality. So delays or improper conditions can impact the effectiveness of the collection. So there was a time in our institution when we collected a commercial CAR T, and unfortunately, due to the delays, the cell was actually left behind by the plane, the airline. So because of the airline delay, because of the flight delay, by the time the cell arrived at the facility for manufacturing, there was already cell death. So it was very unfortunate. That's why it is very crucial for us, you know, nurses who are collecting these cells, that to time everything and make sure that everything is ready by the time we start the collection, especially if we have to ship out these cells for manufacturing. And then 13th is the laboratory processing. So the efficiency of the laboratory processing, including the handling, labeling, and storage of the collected cells, affect the overall efficiency and success of the collection process. And then, of course, the equipment and system requirements. Up-to-date software and calibration and maintenance is very important. So the engineers for this, the manufacturing companies for collection machines, there is a reason why they update their software or their firmware. It is because the goal is always to assist us operators to maximize the cell collection. So when they update their software, it's I would encourage everyone to always use the updated software that they recommend. So by carefully managing these factors, cell collection efficiency can be optimized, leading to better outcomes for recipients and improved overall effectiveness of the collection process. So next, I'm going to talk to you about the endpoint goals of collection. So there's four endpoint goals to each collection. First is the whole blood process, the total blood volume, the runtime, and the product collect volume. If we know our endpoint goal, it is easier to strategize our collection process so we can optimize the collection. So what is the relationship between increasing the inlet rate and the four endpoint goals? When I was a new apheresis nurse, I thought by increasing the inlet pump, automatically I can increase the cell yield, but I was wrong. So that's when I begin to understood that increasing the inlet pump does not automatically increase cell yield. So first is, if the goal is to process whole blood, for example, 15 liters of whole blood to process, by increasing the inlet pump, we can process whole blood faster. We can decrease patient or donor time on the machine, but this does not increase collection efficiency. The next endpoint goal is total blood volume, for example, to process 3 times TBV. So by increasing the inlet pump, we can process 3 times TBV in a shorter period of time, but it does not necessarily increase collection efficiency. Another goal is the collect volume. So another goal is the runtime. So in our institution, we actually do our collections by time. It could be 5 or 6 hours. So by increasing the inlet pump, if the goal is runtime, we can process more whole blood, and it could increase the collection efficiency, because by increasing the inlet, we are actually processing more blood and collecting more cells into the product bag. And then the last goal is, of course, the collect volume. So there are collections that would specify the goal is to collect a volume of 250 ml, for example. So by increasing the inlet pump, we can process more whole blood faster, And this could increase collection efficiency because a higher pump rate increases the blood flow through the apheresis machine, which leads to a greater volume of blood volume process. So a higher flow rate can sometimes improve the collection efficiency by separating the target cells from the other blood components. However, um, it is essential for us to ensure that increasing the inlet rate does not negatively impact the donor or patient's safety and the quality of the collected cells, which may lead to potential complications such as hemolysis. So we still have to be careful every time we increase the inlet pump. I'm going to talk to you today about some settings that we can adjust on both the Spectra Optia and the Amicus because we use both machines in our institution. So first is the inlet pump flow rate again. So Terumo advises that slow and steady is better. So a steady inlet flow rate equals stable interface. So a stable interface minimizes pressure alarms and optimizes establishment of interface and separation of the cells. So it's better to have a lower inlet rate as long as it's steady rather than aiming for a higher inlet rate but with frequent alarms because the vein or the line is just not tolerating the flow rate. Or worse, increasing the inlet pump rate may lead to citrate toxicity. So if the catheter or vein cannot tolerate a higher inlet flow rate, reduce the inlet rate to optimize the collection. Next is the collection preference. So if you're an Optia operator, we all know this adjustment to the collection preference. So what is the purpose of collection preference? So the collection preference controls the concentration of cells flowing through the cell port, flowing to the collect port. I'm sorry. So this needs to be adjusted accordingly to the target cell collection. So if you're collecting CAR T cell, then you know that you have to stay within this color. And if you're collecting granulocyte, for example, then you have to adjust it to make it darker. And one thing that I learned as an apheresis practitioner is that we don't always go by numbers. Um, we always go by the color. And this is also what Terumo would advise everyone who does collections. Because there are times that my collection preference is already at 70, for example, HPC, CMNC collection, but the color is still very dark. So it just depends on your patient's physiology. That's why it needs to be adjusted according to the color, and always make sure that you have proper lighting. If needed, use your cell phone light to light that CP, the tubing, because if you don't have proper lighting, you're not going to get the right color. And next, I'd like to talk to you about product yield versus purity. So what is purity? So high purity is crucial because it ensures that the collected sample is predominantly composed of the cells needed for a successful transplantation or research. So contaminants or unwanted cell types can affect the effectiveness of the treatment or the quality of the research results. So a good example would be for collecting for IRB or CAR T cell or incompatible allotransplant. So we have to make sure that your product is pure. Um, and of course, the yield is also important. So, what is the yield? When we say cell yield, it refers to the total quantity of desired cells collected from the patient or donor. So, for transplantation, a higher yield might improve the chances of a successful engraftment and treatment outcome. So, both purity and yield are crucial for for the success of the stem cell and CAR T cell therapies and research because they directly influence the effectiveness and quality of the treatment or experimental outcomes. Next, I'm going to talk to you about adjusting the anticoagulant ratio. So high anticoagulant levels can increase the risk of side effects such as hypocalcemia, which can affect, your patient or donor safety. But a low anticoagulant ratio may also result in clotting issues, which can obstruct the blood flow and reduce cell collection efficiency. So clotted blood can lead to machine blockages and poor cell separation. So the AC ratio directly impacts the efficiency of cell collection. So an adequate amount must be given for a successful outcome. And we also always have to think about our patients or donors connected to the machine, because ACDA can drop the calcium level. We have to always supplement them with calcium prophylactically or as needed as they start having symptoms. So this is a screen of the Spectra Optia. So when we enter our parameters and prime our machine, the Spectra Optia gives us an inlet ratio of 12:1. If we would like to increase collection efficiency by, increasing the inlet, we can make adjustments to our AC ratio. You can increase it to 14, for example. And if you notice on both screens, by adjusting the inlet ratio to 14, it allowed us to increase the inlet rate from 58.6 to 68.1. However, we have experienced in our institution that by increasing the inlet rate, because Optia gives us a preset of the a preset number, and if we mess with this number, consequences can happen. So in our institution, by a, this was the time when we were experimenting, like how can we optimize our collection efficiency. And one of the ways we tried to do that is by increasing the inlet ratio. So what happened was, we noticed that we had more patients having citrate toxicity. So we were like, what's happening? Like in a day, if we were collecting on 20 patients, we would have like 3 to 5 patients having citrate toxicity. So what we realized is that when the nurses increase the AC ratio to 14 from 12, for example, it gives us that inlet of a recommendation of inlet 68.1. But what happened was that some of the some of us nurses were actually increasing it above the recommended setting, for example, of 75 instead of 68. So when we adjust this inlet and increase it, what happens is that the AC infusion rate also increases. So our patients actually end up getting more um, you know, anticoagulant compared to if we just remained with the recommended setting. So increasing the AC ratio may allow you to increase the inlet rate. However, monitor your patient for citrate toxicity and administer calcium supplement if needed. And when we monitor our patients for citrate toxicity, it's kind of challenging when they're asleep, because we also had an incident at work when one of the donors, she was a lady on the smaller side, but she was asleep during this whole collection process. But by the time she woke up, she was already having arrhythmia, and like you could tell that the citrate toxicity is severe. So I guess what I'm telling you is that when you are making certain adjustments to your settings, if your donor or patient is asleep, we still have to check on them, like check on them hourly and ask them if they're okay. So at City of Hope, we give calcium supplementation. We can give them PO, calcium supplementation, before the collection, and also we give it to them prophylactically during the infusion process. And if they come back for another collection on day 2 or day 3, what we do is already give them calcium supplement like PO before they even start collection, because of that history of having the citrate reactions. And keep in mind that smaller patients are actually more sensitive to citrate. So collect slowly. It's better to collect slowly and collect those cells and keep your patients and donors safe, because once they have reactions, it's going to affect your collection efficiency. So the anticoagulant ratio is crucial for ensuring effective cell collection during apheresis. So proper adjustment of this ratio helps to optimize collection efficiency, maintain patient safety, and just enhance the overall performance. An exemption of the ACDA ratio, it would be actually our patients who have sickle cell disease. So at City of Hope, previously we collected our SCD patients the same way we collected our regular auto patients, such as patients with lymphoma or multiple myeloma. However, after attending the ASFA this year in Las Vegas, I really learned a lot from the talks, especially how to collect effectively on SCD patients. So what we did in our institution after I came back from ASFA is that we followed the recommendations. So automatically, when we begin our collections on SCD patients, we drop our AC ratio to 8:1 for the first hour, or at least 1000 ml volume process, before we adjusted back to 10. But we never adjusted back to 12:1. And when collecting on SCD patients, we go deep right away, because typically we collect use on a collection preference tool like a salmon color. But for SCD patients, we go deep right away. It's almost as if we're collecting granulocytes. And if the patient's H&H is low, depending on their symptoms, the MD can always order blood transfusion, the night before the collection or after the collection. And what we found out by applying this method and this parameter, it actually improved our collection efficiency when we're collecting on SCD patients. Like, it's actually better than collecting on a regular auto patient. Like, for example, we had a patient with a pre-CD34 of 50, but we were able to collect 10 million cells in a day. So it really helps. Um, Next is I'd like to talk to you. I'm going to move on to the amicus because I don't have a lot of time to discuss everything. So I'm just discussing the important parameters that we can adjust. So what values can we adjust on the amicus to optimize the run? When you set up the amicus, it takes after you prime the machine, it takes you to this parameter screen. So amicus is a cyclical procedure. So it processes blood based on the programmed number of cycles. So I'm not sure if you can see my cursor, but it's over here. Um, for example, if you wish to process 12 liters, you can program 1000 ml of whole blood process per cycle of 12 cycles. So um, there is a data supported by previous collections from Fresenius that when your patient or donor has a WBC of above 25, process 1000 ml whole blood per cycle. Um, if their WBC is below 25, process more per cycle. Process 1400 ml of whole blood per cycle. And this, when we applied this in our institution, it helped increase our collection efficiency on patients collecting on amicus. Now, for small patients or patients with low TBV, you have to adjust the volumes according to your physician recommendations. So another good thing about the amicus is that the ECV of the kit is actually lower. The ECV is 160 ml. So if you have patients who need blood prime, for example, or children, like small children, um, it is actually good to use amicus because it has less ECV in the kit. So the screen automatically displays a custom prime if needed. Um, and when the kit volume is greater than the configured percentage of total volume. So for City of Hope, um, like personally, as an apheresis nurse, if I have like a five, like a school age child, automatically I just put them on the amicus because the ECV is lower. And there are times that um, the Optia would require a blood prime, but the Amicus will not require blood prime. So if you use both machines, just put the patient parameters in both machines and see which one would be more efficient for your procedure and safer for your patient. Okay, so the next screen is actually if you're an Amicus operator, the next screen that you would see is the enter additional parameters. So the MNC offset and RBC offsets are parameters that are programmable in an Amicus. So we use an MNC offset of 1.5. I think this is an old slide, I apologize, but we use an MNC offset of 1:5 and an RBC offset of 6. So we on Amicus, there is also what you call a mini cycle. So mini cycles occurs after the program number of cycles have completed and allow for the collection of any remaining cells that's left in the chamber. So we suggest setting the RBC offset to 5 to reduce the RBCs for the final product. This is also recommended by Fresenius. In our institution before, we did not care so much about the mini cycle. What mattered to us was, processing the program number of cycles. But after speaking with the trainer and the engineers for Fresenius, they highly recommend that we complete the RBC offset because after we recycle the program number of cycles, there are actually remaining cells in the cassette, and we want to make sure that we collect all of these cells to improve the collection efficiency. So in my screen over here, it just shows you the RBC offset for the Amicus. So the RBC offset setting allows for tailoring of the collection based on the individual patient needs. So the operator has the flexibility to adjust this parameter at any time. Typically, it's adjusted after observing the first transfer of the MNCs. Uh, However, you can always adjust it accordingly throughout the procedure. So the goal is to observe and adjust. At City of Hope, when we collect for our autologous patients, we automatically just put an RBC offset of 8. The reason why we do that, because I realized that when we are processing per cycle, for example, a cycle of 1000 ml, if we put our RBC offset to 7, and then by the time it's done processing the 1000 ml of blood and transfers the MNCs into the product bag, if the color is still light, then we already lost the cells from that 1000 volume process. So by adjusting the RBC offset darker right away during the first cycle, and then adjusting it to lower like 7 if needed throughout the next cycles, we actually found out that we were able to collect more cells during the procedure. So the way to look at it is that, for Optia, the way to adjust the color of the cells of your target cells is by using the collection preferences. The Amicus is actually by using the RBC offset. So higher RBC offset equals more MNCs. However, you also collect more CBCs. So this is when the product purity versus yield comes into play. It just depends what type of cell you're collecting. And as you can see on this screen right here, the purple ones are the MNCs. So the higher your RBC offset, the longer the harvest point is. That's the reason why the higher the RBC, you're able to collect more MNCs. So an example here is an RBC offset of 8.5 on this screen down here. And up here is an RBC offset of 6.8. So longer MNC harvest requires increased RBC offset to fully capture the MNCs. So Fresenius recommends that if your patient or donor has a high pre-CD34 count, to collect dark. But if you're collecting on an allogeneic patients, you have to make sure that their ABO at least matches before you collect dark. Um, Another good thing about Amicus is that because it collects by cycle, it continuously returns the platelets and plasma to the patient or the donor. It's just the way that their chamber is designed. It causes platelets to elutrate and recirculate with the plasma and exit through this, what you call a PRP port. So again, talking about efficiency, we're not just concerned about the cell yield, but we are concerned about the overall health and possible outcome or side effects or adverse reactions to our patients. So at City of Hope, if we notice that we have patients whose platelets are trending down, for example, they come to us for a 3-day collection. Day 1, their platelet is 150. Day 2, it's like 90, for example. So when this happens, automatically on day 2 and day 3, we put them on the Amicus because it's platelet sparing. And if we have patients too that from day 1 they have a low platelet, then we also put them on an Amicus. So each machine, Optia and Amicus, actually both have their own. I guess they're both really good machines, but they also have their differences. So as the operator, you have to decide which is actually better for your patient and the type of cell that you're collecting. This is just a screen where it shows the MNC transfer phase. So before the MNC are transferred into the container, there is actually a plasma bag on top of this. So what happens to the platelet is that before the MNCs are actually transferred into the MNC bag, the platelet are automatically sent up to that plasma chamber and then released back to the patient. So the patient gets diverted back to the patient or donor to minimize the platelet loss. That's how it is a platelet sparing machine. So it is a huge benefit if you have a patient with low platelets. And this is just a technique that's from Fresenius. So since the process is per cycle, for auto, we go deep right away. An RBC offset of 8, like what I said, and then just decrease it um, according to the color as you're running your procedure per cycle. However, though, an exemption would be if you're using Amicus for collecting CAR T cells, like for IRB or commercial. For this, you have to do the opposite. You have to start with an RBC offset, for example, of 6, because you need your cells light, you need it pure, with less RBC contaminants. And this screen just shows you the MNC harvest length may increase with, increased cycle volume. I'm not going to read that for all of you, but just go ahead and read it from the screen. So non-mobilized donors or patients, you can increase whole blood per cycle and do fewer cycles, which aids in lower RBC contamination in the product. So for example, if you have non-mobilized donors or patients who are poorly mobilizing, the recommendation from Fresenius is actually to increase more blood and fewer cycles. So for example, per cycle, you would process 1800 ml of blood, and instead of processing 15 cycles, you're only going to process 10 cycles. The rationale behind this is that they said it increases the dwell time of the cells inside the machine. That way, when you transfer your MNCs, you actually collect more cells. This slide is actually a recommendation from Fresenius Kabi for stimulated donors. So unstimulated donors for RBC offset with a minicycle, they recommend a offset of 5.0 ml or lower if desired. But for a stimulated donor, they actually also recommend 5. So at City of Hope, for both stimulated and unstimulated patients, we use a preset of 5. So reduce RBC offset for shortened cycles. So for example, if you're collecting, let's say your collection is timed for us here. So for example, we are nearing the 6-hour mark for our collection, and our whole blood processing cycle is 1000 ml. And if we adjust it to 200 ml because we're nearing the time, then from an RBC offset of 8, for example, we have to drop it down to 6. This is just to prevent, collecting unnecessary RBCs from the patient or donor, and it also minimizes the RBC contamination in the product. So the whole blood flow rate, just like the inlet rate for the Optia, also affects the efficiency of the cells. So common settings is actually from a blood flow rate of 15 to 65. So I know my slide says 85, but actually it's according to Fresenius, the recommendation now is only 65, because the rationale behind that is that if we are collecting too fast, what happens if they, especially if they have a high pre-CD34 count or higher cell count, it's going to spill out of the centrifuge, and we're not going to be able to collect those cells. That's why they don't recommend collecting at a very high rate. And of course, if you collect at a higher rate too, you're risking now your patient or donor to have citrate reactions. So some facilities may choose to skip the mini cycle, but again, Fresenius Kabi recommends completing the mini cycle to harvest all the remaining MNCs in the kit. So what are additional parameters that affect that enhance collection efficiency? I'm almost done with my presentation. So for us here, well, especially for me personally as an apheresis nurse, I realized that processing aggressively and deep for the first 4 hours it has also improved collection efficiency. So I'm talking more about your autologous patients. When I say aggressively, it means the highest inlet rate and the darkest color that the patient can tolerate. So usually, and by doing this, I'm making sure that when I'm processing that whole blood for the first 4 hours, I am actually capturing and collecting all the cells that I need. And usually after 4 hours or collection, 4 hours of collection or after a certain blood volume has been processed, um, all we are collecting are the remaining leftover circulating cells. That's why I noticed that by doing collecting deep and aggressively for the first 4 hours of my collection, I've noticed that the collection efficiency is actually higher. Another additional factor that may enhance collection efficiency is by using a formula. So we use this formula for all of our allogeneic procedures, but it can also be used for autologous. It's really up to your institution. So this formula is not ours. This was from a published article that when I cannot remember, but it's in my resources. The link to that published article is in the resources. So by using this formula, we actually optimized our collection. We we not just collected more cells, but we collected them in a shorter amount of time because previously we collected all of our allogeneic patients for 6 hours. But because of this formula, we realized that we don't really need to process that much blood volume, or we don't really need to put them on the machine for 6 hours. So there are times that if their pre-CD34 count is high, then they're only on the machine for like 3 to 4 hours. So by this, we are optimizing our overall process. And another additional factor that enhanced our collection efficiency is by giving upfront Mozibil to both our multiple myeloma and lymphoma patients. Because again, previously we only gave Mozibil to poorly mobilizing autologous patients, and especially multiple myeloma. But then we started giving Mozibil to both patients upfront. So when I say upfront, it's before their first day of collection. And because of this, it actually shortened their collection days to 2 to 3 instead of 4 to 5, for example. So by this, we were also able to optimize our staffing, and we were able to accommodate more procedures such as commercial CAR-T and research towards the end of the week. And here are my resources. And this concludes my presentation. And if you have any questions, I'll be here. Thank you.
Thank you, Deisen. So as mentioned, so this concludes the presentation segment. And so we will now begin our Q&A. And so we actually received just one question so far. So Deisen, please take a look at your screen.
I don't see any question, Ernest.
In the question box, I've just assigned you. We're getting more in. We now have 3 new questions, a total of 3 new questions.
Okay. So I popped out the question box, but I don't see any questions.
Okay. Well, I guess I'll try to read the questions and then. So please bear with me if I'm pronouncing any words wrong there. First question comes from Michelle. How much PO and IV calcium do you administer prophylactically, and then if the PT exhibits citrate toxicity?
So for our PO calcium, we give 1,000 milligrams before the procedure. But this is only on adult patients. We don't give them on pediatric patients. And then for the calcium infusion, for our adult patients, we use calcium chloride of 2,000 milligrams. And we adjust this according to the inlet rate. So the higher the inlet rate, the more calcium we give them. We use a formula for this one. And if they are having citrate reaction despite of the prophylactically administered calcium, we give them 500 milligrams of calcium gluconate that's IV pushed. So yeah, that's what we do. And next question, Ernest.
Sure. Can you note, so this is from Kira, sorry. Can you note how deep on the cologram you aim when collecting SCD, sickle cell disease, I would assume?
So um, the I'm trying to look for that slide. Were you able to see my cursor earlier?
We can try again.
Oh, okay, hold on. Let me go back to that slide. So on the collection preference, we actually, for SCD patients, we go dark, the darkest one. It's like you're collecting for granulocyte. Um, the only factor to consider is what is your patient's hematocrit and hemoglobin, because if it's low, then we need to let the physician know that the patient might need blood transfusion before or after the collection. So we go dark. We collect as if we're collecting granulocyte. I hope that answers the question.
Okay, so the next question then is, for pediatric patients, have you had any troubles with clumping in the machine during procedures? We have adjusted Intel, AC ratio, and have used heparin in the past as well.
We have not experienced, unfortunately, or fortunately actually, on regular pediatric patients, but we have experienced them on sickle cell disease pediatric patients. But these are not small kids, these are like teenagers. Um, what really works for us is to adjust the AC ratio down to 8 at the start of the procedure. And we only use anticoagulant, we don't use heparin. And I have done collection where I have to keep the AC ratio at 8 throughout the whole collection process. And this is how it actually helps get rid of the clumping.
All right, our next question is a request asking you to put your presentation slide, your resource slide back up. But I'll also note that the presentation slides will be submitted will be provided to all registrants. So if you require more time to look at the resources, or if you want to click into the link, you can do so. So I'll move on to the next technical question then, which is, do you use also heparin as an anticoagulant with the citrate?
We don't. We have a policy that we can, but we typically don't. We just use the ACDA. We use HESPAN for collecting granulocytes, but for regular HPCA cells or CAR T cells, we only use ACDA.
All right, next question. How does midpoint CD34 testing results change your parameters? Does your team change the packing factor on the Optia?
So at City of Hope, we do not do mid sampling just because of the risk for contamination. So we do not do mid sampling.
Okay, next question. What are your average collection efficiencies for both Optia and Amicus machines? How often do you assess the CE?
Um, we do have a data, but it is something that I need to ask permission from compliance before I release it. So I don't know if there's a way for me to reach out to the person who sent this question. As soon as I have permission, then I can send it via email.
Sure, I'll capture his name right now and I'll send that to you after the webinar. Okay, so I see we have 3 minutes left, so maybe just enough time for about two more questions. I do appreciate all those questions coming in. We have a lot coming. Okay, so the next question is, could you review the predicted CD34 count again? Is the kilograms based on the donor's weight with pre-CD38 count?
Let me get my formula. Yes, this is based on the donor's weight for us to determine how much total blood volume to process.
All right, I think we have just enough time for one last question then. So here it is. Is 6 hours your maximum collection time? If yes, could you specify if there are circumstances you would continue the collection?
Yes, 6 hours is our maximum collection time, but there are times that we collected on NMDP patients that we have to process longer than 6 hours. I think the longest one that we have done is like 7.5 hours. Um, but this all depends on the donor. If they agree, then we process it. But we really have to make sure that they're comfortable and they are safe. So on rare occasions, we process over 6 hours. I would say it's only for our NMDP patients because for our allogeneic patients, we can always tell them to come back the next day.
All right, so I still see a lot of unanswered questions. So we apologize if we couldn't get through your questions. Please email head office, ask for head office, and we will forward your questions to Deisen to answer at a later date. But in the meantime, we will wrap up this webinar. So thank you all for joining us today. As I mentioned earlier, the presentation slides will be sent, as well as the webinar evaluation and continuing education credits will be sent by email later today. Please join our next webinar on September the 17th, Apheresis Awareness Day. The webinar is entitled Cellular Therapy Collections in Pediatric Population, presented by Mitchell Maynor-Scheigen. Thank you again, and have a wonderful afternoon or rest of your day.
Thank you, everyone.